Hello, this is Dawn Thompson with my amazing co-host Nicole Harlot, and we have an incredible guest today, Rixa Freeze. We're going to be talking about twin birth, and I'm sure we'll get into breech because that's really just the incredible work that you have done between both of those things. Rixa has done a study on twin birth that I think is incredibly important with so many, almost all, and I'm sure you can give me some actual statistics, but almost all women now delivering with multiples are having surgery and not even given the opportunity to labor. And it's really, really, really unfortunate. So we're going to talk about that a little bit today. Rixa, thanks so much for being here. Please just briefly introduce yourself. You don't need to do like a whole bio or anything, but just tell people who you are, what you do, and what your place in the world is.
Yeah, sure. So yeah, hi, I'm Rixa Freeze. I'm involved in lots of things in the birth world, and I've kind of evolved from researching home birth and midwifery and unassisted birth at the beginning of my career and my grad school days, and evolved into breech birth and twin birth. So those are my big research interests right now, and I run Breech Without Borders, a 501(c)(3) nonprofit, and we do breech training and twin training all over the world, and are really trying to advance the option of a vaginal breech birth and vaginal twin birth for every woman in every community. That's our goal. Just a small goal,
Just a small one.
not a big
Yeah.
deal.
Yeah, I'm like, oh, my personal mission statement is to reduce the unnecessary C-section and induction rate. That's my personal mission statement. So I understand. Like, just no big deal. No big
Yeah.
deal. Well, let's just start with maybe, can you give us a little history of how you got here and like what drove that? Because everybody's got some sort of personal story, right? Of how we get to this insane advocacy work that we do.
Yeah. So I got into the birth world generally in my grad school days, and I stumbled across home birth and midwifery and fell in love with it. Like it was an instant thing. Like this is my life passion. I want to do this thing. Breech came along kind of gradually. I was kind of interested in it as a side thing, but I was really focused on home birth and midwives and unassisted birth in the grad school years. But I always had my eye on the breech world because it was so interesting, especially physiologic breech. So I would go to the conferences and do a little bit of research enough that I could present at the conferences because I was an unemployed, grad student slash new grad. And I was like, well, if I present, I don't have to pay the conference fee. So, being all thrifty and everything. So kept my eye going on that. And when my youngest, I have four, when she went to school full time when she was 3, which we do over here in France, I had time to myself every day. And it was a miraculous thing if you've had lots of children and then all of a sudden they're in school and you can do stuff. So that's when I
Yes.
really started getting into breech. That was about 2016. And I didn't really know that I was going to become a breech specialist and let alone run an organization. I had no plan of that. I just thought I really want to specialize in this more. So how about I just learn everything I can about breech? So I was like, okay, I'm just going to sit down and read everything in PubMed from the beginning to present about breech. No big deal. So, about a year later, I finished.
Right.
And because I was reading like every article I could get, systematically going through every single one, getting the full text whenever I could, and I was also organizing everything I found and making notes of where it was and categorizing it. I had this big body of knowledge that I had, and because I had the time and the patience and the, what's the word, high tolerance for boredom that you have to have if you're a researcher, I was able to find all these interesting things and connect things together because I had been looking at the entire body with no restrictions, uninterrupted. And that led to a series of people inviting me to give lectures, and that invited me to more lectures, and then people started inviting me to breech training workshops and conferences. And it slowly evolved into a series of lectures that I was giving that lasted about a day, and then I would find a local breech provider, and they would do another day of training. And I hit it off with Dr. David Hayes down in Asheville, and we really liked teaching together. So that started Breech Without Borders. Not the organization, I'd already started that, but it started our close to what we do today, which is these intensive vaginal breech training workshops that are a combination of didactic lectures and then a lot of hands-on practice. So that's a really quick overview of how I got into this crazy world. And we added twins after a couple of years because half of all twins have at least one breech presentation, so they're really, really interlinked. And so when we brought Christine Loria on board in about 2020, 2021, she had a lot of twin experience as well as breech, and she came up with the idea of teaching this master class that goes more into depth with breech and twins. So I've started getting more into twins, and then Stu Fishbein invited me to co-author his paper on the home birth of twins, which we will be talking about.
Right.
I also have another paper in the work about twins with some amazing Italian obstetricians who are trying to up the cesarean or lower the cesarean rate and up the vaginal twin birth rate. So we're doing a study of implementing some different policies into their hospital and the before and after effects. So twins are also very interesting to me because of the intertwined part with breech, but also that we face the same issues. Really high cesarean rate, lack of informed consent, lack of choice. Cesarean seen as the safe option that's no big deal. Nobody's really informing them of the risks of cesarean. It's all about the risk of twins and the benefit of cesarean. So it's the same battle we're fighting, just with two babies instead
Yeah,
of
I
one.
mean, this has probably become one of the main things that I talk about, like especially on my TikTok and channel, is informed consent, and the fact that people believe, oftentimes medical professionals believe they're giving informed consent, but it's not all encompassing, right? They're just only giving them often one side of the story and not the additional risks on the other side, right? And I think that, cesarean has just become so like no big deal. And I just want to share this because it's happening to me currently. And so I want to talk about it because I had cesareans. I had three of them. And I'm now 51 years old. I'll be 52 this year. And I am in constant pain every day in my pelvis, every day. And I know now that this is about the scar tissue that has developed in my abdomen. And a lot of people will likely suffer similar symptoms and have no idea that it was related to their cesarean. And that's a problem. But obviously that's a completely different subject, but I think that it's an important thing to understand that people just only look at the short-term risks on some of these things and rarely the long-term risks of what cesarean means to the body. And it can actually cause a tremendous amount of damage for long term for the rest of their lives. And those are not things that are being studied in my opinion about, like, I'd love to have a study where we are looking at women 20, 30 years later and seeing what their body is going through. But that just doesn't exist to my knowledge. I mean, if you know of something, let me know. But so let's dive in a little bit to this, like the history of twins becoming, they coincide with breech, right? Of it being like, oh, now we have to do a cesarean if you're pregnant with twins. It's just like an automatic for most people. So can we talk about that a little bit? Like, what's the history?
Yeah. Let's see. So twin births, I'm trying to see if I have it cited in our paper. The C-section rate for twin births rose, and I don't know what it was back in the 1970s and earlier, but I would guess it's also no higher than about 5%, which is about the cesarean rate up until 1970. And then it started going up for all births. I do know that by 2013, that's the last year that I could get reliable data when I was researching for this paper, the C-section rate for twins was 74.8%. So 3/4 of all babies have C-sections for twins. I'm guessing that it probably lagged behind breech. I think breech was the first thing to really see a boom in the cesarean rate after cesarean sections became safe in about the mid-1950s with the new low transverse incision technique. By 1960, people are already starting to publish papers about breech, saying we should section every term breech, and that started to become very interesting to people. But we have the same issue of de-skilling with twins as we do with breech, and the same catch-22 that we find ourselves in, because even though it's just a birth and then just another birth, there are certain skills that you need with twins. If the second twin's getting into trouble, you need to know how to get it out quickly, for example. And then you need to know how to do breeches, because almost half of all twins will have at least one breech, if not two. So it's really intertwined with breech. You almost can't separate it out. And we don't have any studies that were definitive, even if they were flawed, like we do with Breech. So with Breech, we have this one study called the Term Breech trial that in the year 2000 randomized about 2,000 women to C-section versus vaginal birth. And because in the short term it did have better outcomes for cesarean, that's led to the recommendation of doing C-sections for everybody. We know that the study had a lot of issues, a lot of flaws, and now a lot of people are saying that we should not be taking it that seriously. There's a lot of good data since. We didn't have an equivalent study like that with twins. And when we actually did much later, called the twin birth study, where they randomized women to having vaginal versus cesarean, guess what? No advantage to cesarean, but yet it didn't slow the C-section rate. So even though we have a randomized controlled trial of twins that were the first twin had to be head first, which is most twins, but not all. Even though that was an RCT, and it was, I think, maybe even done by the same group that did the term breech trial, this found no advantage to cesarean section, but it didn't really make any difference. So I think it's a testament to the fact that if you have evidence proving cesarean section is better, it immediately has a high uptake. If you have evidence proving that cesarean section is not better, it has a high uptake. It basically doesn't matter what the study says, it's going to have a cesarean. It's a little bit crazy making.
Well, but I mean, it just points to also the convenience factor and time management factor, right? When there's so many other other circumstances that make it easier for the provider, makes it faster for the provider, makes it more convenient for everyone. It's really difficult to stop a process. I mean, we're seeing that right now in the Arrive trial and the induction of labor at 39 weeks, right? That study came out. It says basically it reduces the cesarean rate. And obviously most people in the birth community groaned in unison because that cannot be true. We all saw it over and over again, those inductions ending in C-section and ending in C-section. Like, there's no way, right? And now here we are, almost 7 years later, and it is absolutely rampant. There's some statistics coming out that are saying it's over 70% of women are now being induced, right? And the C-section rate in California, in this one hospital in California, saw 67% increase risk of C-section since the Arrive trial. So, and I want to touch back though on something you said, because I think some people may not understand what the unskilled part means, right? And the fact that going back in history, they stopped teaching breech delivery in medical school. Correct? When that breech trial came out. So they stopped teaching it. So a lot of what we're dealing with now is the fact that one of my favorite things that Hermine Hayes-Klein says is that what doctors should be saying when they're telling you that breech delivery is not safe is actually breech delivery is not safe with me because I am not trained to do that.
Yeah, exactly.
It's not that breech
it can be very safe. In fact, cesarean section is no safer, but I'm going to make it less safe for you because I don't know what I'm doing because my education was bad. And either, and I'm not saying this to blame individual doctors because they often don't even have the opportunity to learn anymore, but it should be unthinkable that as an obstetrician or a midwife, you don't have training in breech and twins, vaginal breech and twins. I mean, it should be unthinkable. Right. Yeah. Just like it would be unthinkable to send an obstetrician off with no training in cesarean section or some of the other things they do. You wouldn't think of it. You wouldn't allow it. It just would not be done.
So let's talk about, really get down into the deep end of the research that you did and what you did, what you discovered, kind of let's go a little deeper into it.
Sure. So to recap some other important background information before I get into the study. So like I mentioned, there had been a lot of studies on twins. There's that randomized controlled trial and a lot of other studies that are large multi-center studies or really good studies. And there's really not any good evidence at all that suggests that cesarean section has an advantage as a routine thing for twins. In other words, vaginal birth should be the plan unless there's a really strong indication for cesarean section, and most women should be able to have vaginal births of twins.
What would those indications be?
Well, it's a specific thing that comes up. So, a mother or baby become very unwell, like, preeclampsia an induction doesn't work, or, these things that require, you could have twin-to-twin transfusion syndrome that, if you don't get it fixed with laser surgery or it doesn't respond, you might need to have an early birth. whether it's induction or cesarean, things like that. Normal medical, like true obstetrical indications where it's not possible to induce and you need a cesarean section. But most women
Mm-hmm.
wouldn't need that, and most women can labor and give birth vaginally to twins in the right
Mm-hmm.
setting.
Mm-hmm.
But
There's also a
and we
lot of
find
people. There's also, sorry, I didn't mean to interrupt you.
okay,
There's also a lot of people though that are there's a lot of providers that say, oh, well, okay, if a patient comes in and says, I want to wait for labor to start with my twins on my own, but oftentimes they're like the response is similar to VBAC. Okay, but you have to by this date.
yeah,
Does,
we'll
is
induce you at
that steep?
37 or 38 weeks. Yeah.
Right? Is that steeped in anything?
Well, I mean, there's some evidence they're looking at just the rate of stillbirth, right? And in population levels, that there is a slightly higher rate of stillbirth after about 38 weeks in twins. But the change is quite low, and then you have to weigh the risks of induction and the risk of having a C-section because of that failed induction, which is a definite thing, and the risk of a baby coming prematurely because the baby's not ready to be born yet. It hasn't gone into labor and signaled to the mother's body that it's ready to come outside. So, as with anything, there's a slight increase in risk, and because there's a slight increase in risk, it's a universal policy now that they don't let women individualize. And some women are are fine accepting a slightly higher risk of stillbirth because the absolute number is quite low. Just like some women are fine going to 42 or 42 plus weeks. It's the same issue that we face with going, 42 plus, going post dates. Risks and benefits, right? But most women are just told it's too dangerous. You must do
Right.
this. We won't
Right.
do it. It's not allowed. And
Right.
that's as far as you get. So, yeah, so that's where we get to this twin home birth study that I did with Dr. Fishbein. And it's really interesting because no one's ever done a study of twin birth at home in any kind of detail. Like there have been some studies that mention twin births as part of a really large data set, but this is specifically focused on twin home births with one provider. We know all the details of everything, so we can really go into depth about
Right.
what it looks like and what's possible in a really supportive setting.
And that's because he's done a lot of twin home births and a lot
Yeah,
of
this study
research.
covered
Yeah.
100 of his sets of twins, so 200
Great.
babies, 100 mothers. Yeah.
That's amazing.
Yeah. So he started doing home birth, I think around 2006 or 7.
Hmm.
And these data is collected from 2011 to 2023, so 12-year time span. And it had 100 twin pregnancies under his care. And of course, some of those risked out before labor. Something would come up prenatally that they would go and transfer to another provider. But 100 of which started with him, and then some of which went somewhere else. Some had twin-to-twin transfusion syndrome. They had laser surgery, and they stayed with an obstetrician in a hospital setting, for example. But we had 7 VBACs among these twin moms, so it's a small number, but still it's great that we have
Amazing.
VBACs represented in twins.
Yeah.
And, this is someone who had a lot of experience doing twins and breeches in a hospital setting before he started doing home birth. And he started doing home birth because hospitals banned VBAC, breech, and twins, which is a
Hmm.
little crazy. So a note to people who are involved in hospital births, especially on an administrative or decision policy making level, don't ban these things, because what you do is it pushes them out into the margins, and I have no problem with that. I'm a home birther myself, but women should never be forced to have an unassisted or a home birth just because the hospitals won't allow it.
Yeah.
So don't
1,000%.
ban it. That's the worst thing you can do. Make it a wonderful thing in your facility. Make it such an amazing place to go that women are lining up at your door to have their breeches and twins.
Right.
That's what you got to do. That's not by banning it and getting your providers in trouble because they're doing their job, which is catching babies, right?
Hmm.
Okay, little soapbox moment. So, what were the protocols? How did he include the mothers? How did he choose which ones to take on? So it's pretty reasonable criteria. So he wanted them to be about 35 weeks or more when they went into labor, and he took di or mono di. So the only one he wouldn't take on were mono, and there's actually some really interesting research about mono. Of course, they have a set of unique risks, but that's another issue. But he took on
Right.
di or mono di.
Well, let's explain that a little bit, because we're
Yeah,
imagining that the average person is watching this, a pregnant person, and so the mono means they are same core, same placenta, same sac, right? Like,
yeah. With mono di, the big thing is that they're in the same umbilical sac. They're not separated by either 1 or 2 layers of sac. So usually most twins are in their own little bag of waters, and sometimes they share a placenta, sometimes they don't. But With a monodi, they're in the same bag. So they can actually swim around each other. They can tie knots in each other's cords. I mean, they can do all sorts of crazy things. They do have a higher mortality rate, usually related to things that happen prenatally. But what's actually really interesting is Dr. Hayes found some recent research suggesting that monodi twins actually can be let to gestate till about 38 weeks, and most of them can start labor and try for a vaginal birth, which is totally against what a lot of the obstetric practice is, which is you have them born something crazy early, like 32, 34 weeks at the most. You're in the hospital from 28 weeks onward, you're and so there's actually research indicating that most of the mortality isn't from the birth. As long as the babies survive the pregnancy, you know, the tangling of cords doesn't seem to cause the mortality during the labor, So that's an interesting issue on its own, and something that I'm not going to talk about too much, but just so you know, there actually is a lot of research pushing back on this, even the idea that mono twins have to be born very, very prematurely and they have to be extremely hospitalized. That's not necessarily the case. It's very interesting research.
Cool.
But back to this, so most twins are di or monodi, and so he could take on most of them. He didn't care whether baby A was breech or cephalic. He just wanted baby A to be longitudinal, either head down or butt down by the time labor started. So he just didn't want a baby A to be transverse during labor. Right. And that's really rare. Usually baby A settles into the pelvis, and then baby B will often be all sorts of things and often change positions, and we don't really worry about that because 20% of babies flip after baby A comes out, 20% of baby Bs turn. So you never know what they're going to do, but we don't worry about baby B so much, but he just wanted baby A up and down and not sideways.
Makes sense.
Yeah. And he wanted both twins growing consistently on their own growth curves. So he didn't care if there was discordance as long as each baby had good growth along its individualized growth curve. So he's a little more relaxed with if there was discordance itself, that didn't really make as much difference as long as they were still consistently growing. It's just sometimes, especially if you have fraternal twins, you have a sibling that's a lot bigger than the other. You have a little skinny mini sibling and you have a big chunky one, and they always are like that even after they've been born and growing up. So, he was just making sure each baby was following a good growth curve. And just no major medical issues, no gross anomalies in the babies. So nothing like type 1 diabetes or heart disease or serious clotting disorders, things that would usually require hospital care anyway. And he wanted women to go into labor on their own. Obviously, we're not going to be inducing in a home setting, and fetal and maternal tolerance to labor. So mother and baby remain healthy and well during labor. And most importantly, really motivated parents, confident, well-informed parents. That was one of his criteria. So that's what we were looking for going into this.
Yeah. I mean, it makes sense that they would be, you don't want somebody who's scared to death and doesn't believe it's possible, right? Because that, mindset has a lot to do with success.
Yeah, totally. So their general guidelines, he wasn't strict. Like if a baby was 4,001 grams, he wouldn't say you're out, even though he had general weight guidelines, but he's he individualizes his care a lot. Yeah. So, he believes really strongly in informed consent, in ethical counseling, and the right to refuse care, the right to say no to things, and the right to individualized decision making. So, he doesn't have a one-size-fits-all policy like everybody does this. I do twins this way. I have a protocol and a routine, and I just stick with it. He just has guidelines, he has suggestions, but he also lets the women choose what they want to do, within his scope of comfort and experience and skill level.
Sure.
Yeah. So mostly he would work alongside a licensed midwife and have a team of like other midwifery students and some assistants. So they had a nice team of usually 3, 4, 5 people at least. In California, where he was practicing, midwives can't attend twins or known breaches. They gave that up in exchange for not needing to be under like supervision, I believe. There was some trade-off they made, and they lost the right to attend breaches in twins. So if you want a vaginal birth of twins, in most places in California, there's very few hospitals that will do it. You are going to unassisted birth, you're going to hire an underground midwife, or you have to go to Dr. Stu, who's now not in Utah or in California anymore. He's in Utah. So I
did not know that. I didn't really.
Yeah, he's down in like near St. George or Kanab, Utah.
Oh wow!
He retired a couple years back. Yeah. Oh. So there's Dr. Victoria Flores who took over from him. So she does twin births at home, and There's another obstetrician in kind of Southern California I know who does twin births at a home, maybe at home, but also in a birth center. But that's about the only options. That's it.
Wow.
And then there's a couple rare obstetricians who might do them in a hospital setting, but for a state with how many million people, there's very few options.
Yeah.
Yeah, I know here in New Jersey, it's illegal to have a twin home birth. So if you're having a twin with a midwife, so if you're
With the
having a
midwife.
twin home birth, you're doing it like you said with an underground, like birth keeper. And I do know someone who is now a midwife, but she wasn't at the time. She was a doula who wound up having a twin home birth, and it was beautiful and the experience. But again, she was someone who was not a first time mom. She was on the track to becoming a midwife at that point already. So it's all about that mindset. And it's unfortunate, honestly. Like everyone I know here, at least, again, New Jersey's a much smaller state than California, but densely populated. So there's lots of people having babies, and it's like unheard of to have a vaginal twin birth in this state. So it's
Yeah.
it's really sad.
Yeah, it's such a shame because almost women can do it. Almost all will if they're given the right environment and if their doctor or their midwife knows what they're doing. And it just shouldn't be so hard. This is their job. This is what they're training to do. And twins are, I think, 3%, 3.2% of all births. Breeches are 3 to 4% of all births. That's a good number. We don't have an excuse to not know what to do with, 6 or 7% of all births. To say we have to do surgery on all of them, it's ridiculous.
Yes.
Not to mention, we know cesareans come with a lot of risks, like you mentioned. There's so many risks that are downstream, that are long term, that emerge over time, that hit the next pregnancy and the next baby. And it's not a minor surgery.
Right.
It's not a small thing to go through. So,
Well, I think the
back
thing that
to
they,
oh,
no,
go
it's
ahead.
okay. I think the thing that they fail to mention is or they'll say, oh, they don't say, okay, so we're going to go in for an induction, and now your risk is, 30%. It's probably greater than that now, we know. All the research, so anybody who's listening to help you understand, all the research is, the national research is about 2 years behind. So it takes us a number of years to be fine before we actually know what's happening. So, but all we know is that all the things are ticking up every time we get the results. It's all ticking up. So,
Yeah,
30 to 40% of the time, your induction is going to end in cesarean, which now no one has told you. They may have told you your risk of C-section goes up for an induction, but they don't talk about what the next birth risk is, right?
yeah,
After you've had a C-section. They don't
yeah,
tell you that, the risk almost doubles for the woman for maternal mortality, right?
yeah. The risk
And
of her next baby dying goes up because of
right,
the previous
well,
C-section.
right, and also lots of miscarriages, right, are very, very common right after a cesarean too. And
Yeah,
some women have, secondary infertility because of C-sections. And this is just not information that's being shared with people. And it's just, this is the thing that makes probably me most crazy. And
yeah,
it's why I love that we're having this conversation.
I
yeah,
think the biggest thing that irks me too is that when this situation happens, regardless of breech, twin, any other reason for cesarean, it's made out to be that the woman's body somehow failed her or she is the cause of why it's happening, right?
hmm,
And that drives me to no end every time because it's not the woman's body. It's the lack of allowance of the body to do what it wants to do or needs to do in order to get that result. It's the system that says, oh, you're on a time clock now, or we're monitoring you, and it's safer for us to do this rather than to let your physiological body do what it's designed to do. But in every situation, it's the mom that is left feeling like, oh, I wasn't good enough, my body wasn't ready, or it was something that I did, and holding that guilt and shame. And where you hold that, excuse me, where you hold that is in your womb space. So it's this like vicious cycle again, like you guys were just talking about with your next child, with your next pregnancy, because you're already going in almost defeated that your last one resulted in that surgery.
Yeah. Yeah.
Yeah.
So back to this paper.
Yeah. Sorry,
So we
we're
had
gonna
these
keep
100 women.
diverting, but it's like,
No,
I
that's
feel like
fine.
it's,
I love it.
yeah, important to bring it back to just like everyday stuff that people are dealing with, right?
Yeah. So there were 31 people who transferred prenatally for various reasons. So, things come up during twins. So people use the word high risk, which drives me bananas because it's a term that has no objective meaning. It's completely up to the person who's saying it. There's no way of saying, yes, you're high risk or not with a test. It's arbitrary. So, yes, twins have a higher risk of developing weird things during pregnancy that can sometimes cause issues, but the birth of twins itself is not high risk. If you manage to not have one of these problems during pregnancy, which are still fairly rare, but just a little bit more than a singleton pregnancy, the birth is not high risk. There's nothing inherently high risk about giving birth to two babies. So we have to really rethink the fact that, oh, you have twins, you're high risk automatically. No, it's not. You might develop a certain condition while pregnant with twins, and that might then lead to you becoming more high risk of a certain thing, like if you have twin to twin transfusion syndrome, where the blood vessels are interconnecting in the placenta when you have identical twins. It's a really short way of explaining it. And the blood flow is dysregulated between both babies. Something that's really specific, but in general, we just want to reframe this that twins are not inherently high risk. They don't have to be. And they can be just fine and just normal if you get through pregnancy. Pregnancy is where most of the problems occur, not the labor and the birth. So the women who transferred out, there were things like Dr. Fishman was out of town and they're already 41 weeks and they hadn't had their baby yet, or they had cholestasis, or they had preterm rupture of membranes like before 35 weeks, so he would send them to a hospital provider. A couple women had developed preeclampsia, IUGR, intrauterine growth restriction, things like that. Some had twin to twin transfusion syndrome and they had to get treated for that. So there were some, various reasons for women transferring before labor started. So by the time labor started, he had 69 women in his care. And of those 69 women, 61 gave birth at home as planned, and 8 of them transferred during labor. And of the 8 transfers, 6 were cesarean sections, mostly because there was not even the option of, epidural and augmentation or whatever they needed. They just went to cesarean because that's all there were. And there were actually 2 vaginal births in supportive hospitals where he was able to transfer to someone who would take them on. So ideally, even those transfers could have probably had a higher vaginal birth rate had there been a supportive hospital that did twins to transfer to, but most of them just don't do twins vaginally. It's cesarean section. So we had a really high vaginal birth rate. Let me look up what it was. Give me just a moment. So 97.9% of multips, so 46 out of the 47 multip moms gave birth vaginally,
Can you
and
just start over,
77.3%.
Rixa, I interrupted you when I was
Oh,
just going to say, don't worry about the silence because we can edit it out.
yeah, you can take it
Just
out.
go
Yeah,
ahead and say that so we get it clear
sure.
without my
I'll start
voice here
over.
with you. Yeah.
Yep. So almost every single multip gave birth vaginally. We had 47 multips, and 46 of the 47 had vaginal births, and 77.3% of the primips had vaginal
So let's
births.
explain that. So multips means they've already had at least one baby.
Correct.
Yeah. So and then the other one is
Yeah,
is
first
their
time
birth.
moms.
Yeah.
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 And that's amazing because the national cesarean rate overall is what, 31, 33%, somewhere in that range. So, and it's, higher for first time moms and a little bit lower for second time moms or beyond. I mean, this data blows anything out of the water that you've seen. Almost 100% of mothers who've already had at least one baby gave birth vaginally, and 77.3, which is what, 22.6%, 7%, had a cesarean if they were first time mom. That's lower than the national average for just a normal average baby. So you see that in the home setting, it really supports vaginal birth, and most women can do it. So, we have really high vaginal birth rates, especially if you have had one or more babies. There's no reason to plan a cesarean short of there being a real strong indication, like absolute contraindication, do not go into labor. You are gonna, there's something coming up that you should not even be in labor for. Otherwise, you can do it, and you'll probably succeed in the right setting. So, what were some of the reasons that they transferred in labor of these 8 women? So a couple of them had just a total arrest of active labor after 7 centimeters, like 12 hours. I mean, they would wait and wait and wait and wait and do everything they could and just stopped. So if they had had a supportive hospital, ideally they would have gone in, gotten epidural, gotten augmentation, and maybe some of them could have gone on, but a lot of them might not have had that option in their transferring hospitals. One of them had audible decels in early labor. One was a VBAC mom, and she felt really sharp suprapubic pain over at 10 centimeters, and they thought maybe it was the beginning of a uterine rupture. They transferred. Actually, it wasn't. There was no rupture, but she had a repeat C-section anyway. And then there's just a couple of like super long labor, maternal exhaustion, kind of a combination of waters being broken for a long, long time, and the labor just kind of didn't really get going. And you can only do so much in a home setting. At a certain point, you need other tools to get over that. So they would transfer in.
Well, you had just mentioned something about, isn't there a statistic? I mean, I don't know if you know this offhand. I know I don't, but I know that a large number of the home birth transfers actually are for maternal exhaustion and or wanting pain relief, and not necessarily because there's anything wrong or that there's a need for it. That's significant, right? I mean, I think most midwives say it's a 70% or something of the women who wind up transferring are because of those things, not because it's emergent.
Yeah, if you look at the 8, we had one that was considered emergent. That was the VBAC mom that they thought there might be a uterine rupture, and there wasn't. But they did transfer her more emergently. Then the other one that had audible decels, it was in early labor. They had plenty of time. The baby wasn't in any kind of really distress, but since they were picking up decels early in labor, they thought they should transfer. So 1 out of the 8 was considered emergent, and even that was not even really a true emergency, it turned out. Most of them were just things aren't really happening. It's just obvious that we can't do anything more in the home setting. Let's go after trying everything we've tried at home. Yeah, that's very true. The thing is that the hospitals, they don't know that context. They tend to see the ones coming in. So there's this skewed perception that they get the train wrecks, that they're coming in, that home births are failing all the time. They're only seeing the ones that aren't successful, and they're typically not received very well. Some hospitals are great, but often there's a lot of stress and fear among the receiving providers. The woman is maybe hostile or stressed out of her mind because it's not what she wanted. She doesn't want to be there. She's resentful, maybe. Understandably, it's not what she wanted and not what she planned for, and she maybe knows she has no option but C-section in the transferring hospital, so she's really upset. So there's a lot of big emotions going on all parties. That tends to skew the perception.
A discussion on TikTok with somebody who was an EMT who said, "Oh, home birth is totally dangerous. I know because I'm the one that has to go, and when they mess up, was kind of the view." And I was like, gosh darn it, I said, you have a really biased and skewed view, because what you don't know is that the majority of home births are safe, fine, and end exactly the way they're supposed to, right? But the other part of this is that you're only getting the call for the ones that need transfer. So it means that the birth has turned either into an emergency and or is just needing a little more medical support. And the thing that I think people fail to understand is this happens far more often in a hospital environment. When you transfer a normal laboring woman to the OR, you're transferring her, right? Like, people don't look at it that way. You are changing just like a midwife does in a home birth situation. Okay, we need more. And so now we're moving to the next thing. They do it in the hospital every single day, but it's not considered the same. It's not looked at the same way. And I think that is so tragic. Like, this idea that, oh, we've screwed up. It's like, no, things changed. And they do in the hospital all the time. And in fact, the hospital system is often the cause for the issue, right? It's the snowball of interventions that happens that led to the baby being in distress, right?
Yeah, I mean, that's why home birth has a consistent C-section rate of somewhere in the 5 or 6% range, give or take a little bit. But that, hospitals can't get that low because they do things that make it harder to have a normal birth. And again, it's not that there are evil, cackling, overlords saying, "Oh,
No.
how can we make birth as bad as possible?" But actually, we've designed a system that makes birth as bad as possible by chance, by default, by, you know, crazy administrative rules, by the bureaucracy that we
Systems.
live in. It all
Yeah.
combines to make a system that makes birth as hard as possible
Yes.
and as
And
disrupted as possible.
it's so funny that you just did that. I do the same. I've said this over and over again. I don't think these doctors and nurses are going to work every day and they go, "Ooh, who can I traumatize today?" Like, I know
No.
that that's not true. I mean, there are some real pieces of work out there who are narcissistic and really don't care. But the most people, that's not the case. And I think that, a lot of people, because of the way I talk, would think I'm anti-doctor, anti-nurse. That could not be farther from the truth. I'm anti-system that has bred them, that has taught them, and they just, in a lot of cases, they've never seen anything different, and so they don't know. And I also talk about how doulas have the most the largest view of maternity care system and maternal health in general. And that is, we see birth in hospital, birth center, different hospitals in our community, different doctors, different nurses, all these things. And we can see what works and what doesn't, and who's doing it
Yeah.
well and who isn't. And it's and what's frustrating is that when you know that it's possible and it's not hard to do it well, it's infuriating. And when you're trying to be the one who is like saying, saying, "Hey, this can be better." And it's not that I'm being critical of you, or like that I disrespect your position or how hard you work. I think it's an incredibly difficult job. I think nurses, doctors, midwives, they have one of the toughest jobs in this country. And I have so much respect for them, but I also know that they could do better. And they could and that we really have things to offer that could be of value, that could even make their job easier and more enjoyable. And I mean, they could have better job satisfaction because their patients are so much happier. But
Yeah.
we don't always get that opportunity because, I mean, you go on my TikTok comments every single day. Are you a doctor? Are you a nurse? Do you have a medical degree? I mean, like every single day, right?
Yeah.
Because I didn't go to medical school, I have no value. And what I have to
Yeah.
say has no value. And it's really unfortunate because if we all came together and started really having these discussions, we could make a huge difference. But instead we're, discounted like, "Oh, she's just that,"
Yeah.
and it
Yeah.
doesn't have the same amount of value, and it's just really unfortunate.
Well,
There's my
and to,
soapbox moment. Sorry.
to your point about the systems too, I mean, this isn't birth related, but I was literally just reading Facebook this morning, and there was an unfortunate incident that happened in Pennsylvania over the weekend with an ICU unit. There was a shooting, and it was because this guy like got delivered news that his loved one didn't make it, and the post was shared like from one of the hospital employees that said like it's not, it, yes, obviously it was his fault for taking this action, but like empathizing with his position and saying how every hospital employee is stretched so thin and the burnout that they have, and because of the system and because of insurance and because of the unavailability and unaccessibility of care, and the way that the systems are run in hospitals, again, whether you're talking about birth or just normal, critical care, it's happening all over. So when it's, when you're talking about injury, illness, disease, that's one thing, right? Like you need hospital care for those things. But when birth, when it is such a normal physiological process that we're medicalizing, that like it's an extra like it
Yeah.
really doesn't need to be this way, where again, if you have some sort of like heart failure or cancer or like there is, of course there's natural holistic remedies, but for the most part, you need that medical care. So I think that puts the extra like twist in the knife, right? Like it's
Mhm.
just really sad to see that so many moms, and if you're listening, hopefully this, listening to the podcast opens your eyes in general, but this specifically, like, opened your eyes to say, like, wow, it doesn't have to be this way. I don't just have to go to the hospital. And another thing that's come up recently, and, I think it's just worth saying in general, not necessarily twin or breech specific, but, having the partner on board, having the family on board, like, that's so influential to the mom's decision of, saying, hey, I want a home birth, I want a birth center birth, I want to do things differently than the norm. And it's like, oh, but my husband's weary or afraid, or, insert emotion here, or my mom or my family won't agree with me. But it's because they're also bred into the system of, well, birth is in the hospital. And I think it's shifting a little bit, and I love, like, these studies are coming to life, and it's being shown a little bit more realistically, but I think we have so much further to go. And Dawn, I'm going to pause here and just say, like, thank you for continuing to share the information, even though, the trolls are saying, oh, who are you to say this? Because realistically, I mean, if anything over the last 5 years has taught us anything, that doctors and medical people and these high astute, people in positions don't really know what they're talking about most of the time. It's just what they're trained and they're credentialed to say. So thank you for continuing to share that information.
Rixa, I know we're getting to the end here, and I know we've kind of like derailed several times about the actual research, but I think that I'd love to know if there's like, what do you think is like the most important thing to take away from the study that you did, and like what the results were, and like what do you think people need to walk away with right now?
I think the fact that, especially if you had at least one baby before, you can almost 100% give birth vaginally in the right setting. And so it's a total travesty to be forced to have a cesarean section. I mean, you don't want the first time moms to have C-sections either, because then they have to have a VBAC for the rest of their lives, right? That also is a tragedy. But, the likelihood of a successful, spontaneous, physiological birth in a setting that supports it is so high if you're a multip. It's ridiculous to be telling a multip she has to have a systematic cesarean for twins. Another takeaway is you have to know breech to do twins, because in our sample it was something like 45% of all of the twins pregnancies had at least one breech baby, if not both.
Yeah.
You can't be a twin provider and say that you're going to attend twins if you don't know how to do breech, because otherwise you're automatically going to have a 50% C-section just because you have the breech in there somewhere. So
Right.
you need to know what to do.
I mean, I love that every time they do one of these breech conferences, there are obstetricians that show up, right? There are obstetricians. I want people to get hope in the fact that there are obstetricians who are actively seeking training in these things. It's not nearly enough. It's not nearly enough. But I want to, if there's an obstetrician listening to this episode, probably not very likely after the conversation we just had, but if you're still with us, I want you to know that there's opportunity out there, and you can learn and you can offer it. And what are do you have anything coming up soon from training standpoint that providers can attend? Midwives, doctors, nurses?
Yeah, we have several in the US. We have one in Australia, couple in New Zealand. We're working on scheduling a lot more in 2025. So if you just go to breechwithoutborders.org and go to our training page, we have a page that says upcoming training opportunities. So we do the vaginal breech training. That's our one-day thing that also has 15 hours of online courses that you take before the hands-on training. And then we have a breech and twins masterclass that usually is the next day in many of the places that we train, where Christine will teach a lot more about like complex and complicated breech scenarios, and also twins. So, there's some good training opportunities available. If you're not close to where we're coming, you can always take our online breech training course. It's called Breech Pro 2.0. That's something that's required if you take our hands-on training. So you can start learning now, and then hopefully you can come to one of our in-person live events. You can also request for us to come train you, and we'll come. We've trained a lot of hospital systems, and we continue to get that demand every year, actually more and more every year. So it's actually really encouraging that we're starting to get such an uptake among hospitals. A lot of hospitals are trying to start breech services, and implement protocols that support physiologic breech in a 24/7 manner. It's a long journey for many of these hospitals, but it's starting to happen. So that's really encouraging to me, despite all the obstacles we face. But there's definitely an agreement that we can't just let things stay how they are, and we can't keep doing C-sections on everybody. We need to know what to do.
I hope Dr. Wu is looking down on all of you because Dr. Wu was a physician, an obstetrician up in Los Angeles, and he was one of the few doctors that was still doing breech deliveries, and the hospital wound up telling him he could not do them anymore. And it was a big deal, and it was overnight, and he had multiple breech birth clients in line, and they basically said, you cannot do any more breech deliveries at this hospital. And we wound up having a protest. We had all the news come out. We had celebrities there because he had delivered many celebrity breech births at that point. And so a lot of these people came out and to support him. These celebrities holding signs out in front of the hospital. I'll never forget it. I'm trying to think of his name, from Dawson's Creek. What's his name? I can't remember his name.
James Vanderbeek.
Yeah, Vanderbeek was out there.
Oh yeah, I met his wife at one of the conferences.
I was gonna say him and his wife are amazing. They're like about natural.
They've done so much. And anyways, and I, and we tried everything to get it back, and they wouldn't. And he decided to quit. He quit obstetrics. That was it. Like 2 weeks after they tied his hands with breech delivery, he was just like, I cannot with this system anymore. I cannot. And he retired. And then he actually passed away just a couple of years later. But I hope that, all those doctors up there that did lots of breech deliveries are, empowering these other folks to do it. And I guess the only challenge is like, what do people do? I know we got to wrap up in a second, but what do people do if you've got a breech baby or if you've got twins and they can't, what do they do?
They drive across multiple state lines, they free birth, they hire underground midwives, they travel, rent an Airbnb out of state. They have to they have to change their whole life and spend a whole lot of money or go way outside the system. And maybe a thing that they don't feel is safe, but it's their only option, like to have a free birth because nobody will help them. The women who don't have resources often just have to submit to the cesarean, which is an unconsented cesarean because they were not given the opportunity to say no. So the ones with resources can kind of escape that a little bit if they have enough money and enough means.
Yeah.
But the ones who don't have the resources to just up and move for 3 weeks and rent an Airbnb somewhere, let's be real, most people can't do that, then they're just stuck.
I'm curious too about the opportunity that a pregnant person has to encourage their provider to do something different too, right? Like, so now you've listened to this episode and maybe you're pregnant with twins, maybe you've got a breech baby, and now you can go to your provider and say, hey, do you know that have you ever heard of Breech Without Borders? have you considered, saying something like, oh gosh, I heard that there's a lot of doctors who are getting trained in breech delivery so that they can do them safely. And, like sometimes that, like just dropping those things, because what we know is that the system has no real motivation to change.
No.
Right? Financially,
why would it?
A cesarean is better. Time-wise, it's easier, like all of those things. So there's no motivation to change this. So it's really, the women are the ones that have to put the pressure on the system to demand it. And so I encourage you, if you are listening and this sounds like something you should do, please do it. Go get your research, go get the documentation to support what we're saying, and go share it. And maybe, Rixa, there's some things that we could share in the show notes that would be an easy resource that people can just, so they don't have to go search for it themselves, but maybe we provide a few links that people can just get the information and be able to take it to their provider and have a conversation.
Yeah. It's
It
important to
doesn't mean
realize
they're
too
going
that
to
a
change
lot
their
of,
doctor's mind, but at least their doctor might consider doing something different and may consider going
yeah,
to one of these trainings.
yeah. And often the providers themselves are so constrained, like they are threatened that they'll lose their job if they do a vaginal twins or vaginal breach.
Yeah,
So it's not even
because they
often the
want to.
providers that are a barrier. Sometimes it is, right? But often it's the department managers, the risk managers, the department chairs, the overlords,
Yeah,
as we might call them. Uh,
administration.
so what I would say is, if you have twins, you mostly know nowadays that you have twins for many months. You have time. It's different with a breech. Often you don't really know it's breached till 35, 36 weeks because they'll turn, and most of the babies will turn. And then if you've got the persistent breech that's not going to turn, you only have a couple weeks really to get everything in order. But with twins, you have time. You know you're going to have a 50% chance at least one or both babies are breech. So you need to be absolutely certain that your twin provider is comfortable with breech, whether it's baby A, baby B, or both. Just get that one out of the way right there, because
Right.
if they're not going to get any better. You have time to start having that conversation quite early.
Yeah.
Expect to have at least one breech baby and be surprised if it doesn't, right? Because then
Right.
then you're good. Um, I think that women need to consistently and persistently make it known that they are being refused the ability to say no to surgery, and that is illegal. That is clearly against every state and federal law out there. And if a hospital won't allow a vaginal birth of breech or twins and won't allow a provider to do that, they're forcing the provider to commit assault and battery, which is a criminal charge. And they need to rate all of the CEOs and the risk managers and every single person on admin, the department chair, CC everybody there and be like, I am not being allowed to refuse surgery at your hospital. This is illegal. And I'm putting you on notice that if I am forced to have the surgery, I will come after you with legal threat because you've been notified that this is not legal. I have a legal right to say no. And if enough women do that, put them on advance notice, like well in advance, I am not going to accept an unconsented cesarean, and if I have a breech baby or twins and you say I'm not allowed to have a vaginal birth, that is not consented. That is assault and battery. You're on notice that you need to not do something that's illegal. Just start there. Get the hospitals on notice that
Imagine.
we won't put up with something that's criminal and illegal,
Me and
right?
Dawn are like so excited right now because just that nugget alone, like mic drop. I'm
Dude, I
telling
got
everyone
goosebumps.
that right now.
I
Like, I
got
have a friend
goosebumps.
who literally messaged me and she's like, "Oh, I have 2, 3 weeks left on breach. I'm trying to do all the things. Can you help me?" And I was like, "Breach is just normal. Like, why do they, throw up the alarms, right?" So I'm totally gonna tell her that.
I think I love that was one of the things out of the Heads Up documentary that I loved was breech is just another variation of normal.
Yeah,
Yeah, we have a little qualification with that. We kind of,
of
Christine hates
course.
that saying. She says we want to normalize vaginal breech birth, but breech birth isn't normal in the sense that it's not very common. And it does require a certain particular skill set that is not the
Yeah.
same as cephalic. And it does sometimes get really tricky and really complicated. So our preference is not to say breech is a variation of normal because people tend to use that as a way to say, oh, it's just going to be just fine. It's all natural and nothing bad can go wrong. That's where it tends to go a little bit.
Yeah.
But let's just say breech birth can be normal and can be very safe with good training and good experience in a supportive setting. And
Yeah.
Of course.
we need to normalize vaginal breech birth.
Yes.
Or as Christine says,
Yeah.
we need to vaginalize breech birth because
I love
she
that.
made a slip of the tongue that we have now turned into a t-shirt. So
Okay.
Love that.
Oh my gosh, Rixa. I knew I was going to love this conversation, and it's been so amazing. Thank you so much for just sharing your wisdom. And I know we dumbed it down a little for us, like, in the conversation, but I think maybe that's not the appropriate way to say that, but
no, we
I,
just went on some wonderful tangents that are actually not really tangential. They're very much appropriate and relevant to the conversation. It's all
yeah,
good.
and I think it's what most women are dealing with, right? I think we're speaking in more simple terms sometimes, and we need to just help people understand, like, it's really easy to get into the minutia of research and all of those things, and it can be overwhelming for a lot of people. Where if we could just simplify, some of these things, that I think that was part of my goal there for sure. But so Rick, so we ask this of all of our guests. Um, what do you think is the most important person, aside from what you do, in a woman's village when she is giving birth?
Oh, goodness. I don't know because so when I was giving birth, I was super solitary. I didn't want anybody even watching me, like not even my husband at first.
Oh,
But but I had support in the way I wanted it. I which meant my midwife. I had an unassisted birth the first time, and then my midwife. I had a midwife the last three, but they respected what I wanted, and they left me alone when I wanted to be left alone, and let me do my own thing. So I don't know if I'm quite answering your question, but in terms of actual who's around her, literally in the birth space, it's so that varies so much. I have a sister who's a party birther, and she wants all the women in a circle telling her she's a birthing goddess and like all the people, and I'm like, no, don't touch me, don't look at me, I'm fine. I'll tell you if I need something. Leave me
I
alone.
think I
So
think it's like just someone who listens to what you want.
yeah,
That's what I hear when you're saying that. Like
me
someone who
too.
listens to the mother.
Yeah,
yeah,
it's the person or people or whatever that looks like. It's the support person, whatever that looks like for you, whoever that is. Maybe it's a midwife,
yeah,
maybe it's a doula, maybe it's your sister, maybe it's your husband, partner, whatever. Like, it's really just that primary support.
Yeah. Well, thank you
yeah.
so much, Rixa. I learned so much. I wasn't talking too much because I had the crazy kids for a little bit there, but I just took it all in, and I so appreciate your wisdom and being here to share it and keep doing what you're doing. It's definitely
Thank you.
needed.
You.
For sure. Let's meet back in like 10 years and see where we're at.
Yeah.
That'd be great to review this and look back and be like, oh my gosh, now we're doing breech all over and birth twins, and I love it. But anyways, thank you so much, and we appreciate you. Uh, be sure, if you're listening, to download the show notes and get all these resources if you need them. And if you need anything else, you can always message us, and we can connect you with Rixa. You all have a great day.